patients remained in buprenorphine treatment, whereas none of the patients in the control group that received abstinence-only treatment did. And this shows that abstinence treatment is not effective for all patients. And these are studies in patients that are not pregnant. So it's interesting to look at just patients that do not have the problem with pregnancy, that abstinence-only treatment is not as effective, and medication-assisted treatment is really more effective. For pregnant patients, abstinence treatment might not be an option at all because, as I mentioned before, they have the risk of withdrawal during detox, and withdrawal of the mother can have detrimental effects in the baby, as I already described. And an alternative is medication-assisted treatment, methadone and buprenorphine. Methadone has been the standard of care for opioid addiction in pregnant women. It is a full mu-opioid receptor agonist, and it controls cravings and prevents relapse. However, like the other opioid agonists, it has a risk of respiratory depression. And an alternative is buprenorphine, which is a partial mu receptor agonist, and it has a ceiling effect. This means that at certain doses, increasing the dose will not produce greater effects. It will not produce greater pain relief, not produce greater highs or sedation. And therefore, it is safer than methadone, as patients are less likely to overdose and experience respiratory depression. Methadone and buprenorphine are FDA approved to treat opioid addiction. However, they are pregnancy category C, meaning that there's not sufficient research in humans to show that there's no risk to the fetus. Use of either during pregnancy should involve a risk to fetus versus benefit to mother consideration, and discussion between the mother and the physician whether the benefits outweigh the risk. This is a slide showing some of the treatments for neonatal abstinence syndrome. The ideas for non